are you?
I'm good, Declan. How are you?
I'm good. Nice to be back in the studio.
Back in the studio. We had a bit of travel.
Yeah.
Whirlwind EAU trip.
Yeah. And so by the time we're posting this podcast, one of our China-themed podcasts, we'll have pushed out 4 or 5 or 6 podcasts from on the road in Spain and in the UK. And
Not to mention the couple of podcasts we did leading up to it, because there were big game-changing plenaries.
That's right. Which we're going to talk about today. Some of the big papers from the EAU.
Yeah. Always exciting to see these surgical trials in the limelight, and this EAU is very special for that.
So plenty to talk about. Mm-hmm. So again, this is one of our themed podcasts supported by our friends at Bayer in China, who are gold partners of GUcast, and as regular listeners and viewers will know, we have a very big interested audience in China who we love chatting with, and so every couple of months we do a dedicated episode where we engage with our China editor Yao Zhu, who'll be joining us in a moment, and a couple of guests from China who want to talk about prostate cancer. And we've had some really cracking discussions over the past year, everything from radical prostatectomy to latest imaging techniques in China.
Doublet versus triplet therapy.
Yeah. Pelvic lymph node dissection, all of our favorite topics. And we know that our friends in China like the EAU, they like the EAU guidelines, just like we do here in Australia. So we're going to have a post-EAU version of our China-themed podcast today. So let's do that. Let's go and chat with our China editor, Yao Zhu, who's joining us again. Yao, good to see you, my friend. How are you?
Good. How are you, Declan and Renew? It's really nice to see you again, and especially post-EAU meeting. We see a lot of exciting science during this meeting, and a lot of Chinese and colleagues coming to this meeting, and it's really wonderful to see you again in GUcast.
Always good to see you, Yao. And you know, we were chatting offline about the EAU, and it really is quite a favorite meeting for you guys over there, and you follow the EAU guidelines very closely. So it seems fitting to have a discussion about, you know, the big events at EAU, the new EAU guidelines that were released this year for prostate cancer. Lots of things to talk about.
Yeah, so I think EAU guideline is quite popular in the Chinese GU community, and it's updated every year. And the EAU meeting is really a shining place for how we can integrate the science into the guideline and how we can implement the guideline into our clinical practice.
Actually, it's a funny. Sorry, go ahead, Zhu. I interrupted you.
I think a wonderful part is this year we have many Chinese colleagues coming into this meeting. So it's really showing that we have a lot of exchange of knowledge and how we can fill the gap of the guideline and the clinical practice in China.
Yeah, fantastic. Actually, there's a funny story about the guidelines, isn't it? Because they were updated as we were en route to Madrid. You were one of the first people to look them up.
They do that every year. You know, it's a long flight from China to Europe, but way longer from here. So every year for the last few years, when we're just getting on the plane, I quickly look at my computer, and there you go. The EAU Prostate Cancer Guideline gets updated, like 300 pages of it. So I have 24 hours to be digesting the latest changes to the EAU guideline. But we want to talk about that, and we've picked out a couple of prostate cancer highlights from the meeting. But now, you've selected one or maybe two. We're not sure yet. Will our second guest join us? Friends from China to join us on the podcast. So would you like to introduce Junlong to us, please?
Yeah, so I'm really honored to invite my good friends in China. Both are wonderful surgeons and urologists in the GU cancer space, and they have the experience to present their data in the EAU meeting, and they are a big fan of GUcast. And the first is Junlong Zhuang. He is a urologist from the Nanjing Hospital and in Nanjing, People's Republic of China. And the other doctor is Liang Yougu. He is from the Department of Urology in Chinese PRA General Hospital in Beijing. And I think they are really interesting in today's discussing.
Well, terrific. Junlong, thank you so much for joining us.
Welcome.
Hi, I'm Murphy. and Renew, and my friend Dr. Chu, and it's honor to be here. And you know your Jucas is very popular around us and all the urologists around the world.
Oh, we
And
love that.
and I went to the Madrid for the EU meeting this year. It's an exciting meeting, and it's a nice trip. And we have maybe 12, we have 12 poster in the meeting,
Wow.
and I guess maybe urologist more than 200 urologists went to that meeting.
Yeah.
And in my center, we went
wow.
we 10 college with me went there. So it's very popular in Chinese, and very popular in the urologist in Chinese. So I'm happy to discuss with EAU this year, and there's maybe the update in the EAU guidelines, and also some hot topic about the clinical trials like translate on Eurosafe.
Brilliant.
Thank you.
Fantastic.
Yeah.
Well, thanks so much for joining us, and congratulations for getting so many posters accepted. The rejection rate is like 80% for the EAU meeting, and so it is a very good meeting to get your work presented at.
Absolutely.
And you chaired a big poster session.
Yeah.
And, it's one thing to have the big plenary sessions where the big speakers come and present the big stuff, but always in the poster sessions, it's where you get to interact more with colleagues, and you're presenting your own data, and you get a lot more discussion, don't you? So it's got everything, and courses. I like the teaching courses. We ran courses for European urology as well, and and hopefully now Dr. Gu is not with us online yet. He may join us during the podcast, or we may end up editing in a little segment later on. He was having some difficulty joining us, but we should get going, Renew. So the three things we wanted to run over were the EAU guidelines. I'm going to just briefly say the things I noticed. Not too many big changes this year. And then two big trials that made a lot of headlines, as Dr. Junlong said, the Translate trial, which is a randomized trial of transperineal versus transrectal biopsy. How will this be interpreted in China? And the NeuroSafe trial, the randomized trial of frozen section nerve sparing. So we're really interested to hear how this is being interpreted in China as well. But I think from the EAU guideline point of view, as you say, we had 24 hours to read 300 pages. And helpfully, actually, at the start of the EAU guideline document, each of the sections, prostate cancer, kidney, they have a nice section where they summarize the changes from the previous year, which does help a lot. Amazing group of people, the EAU Guideline Committee, Maria Rabal, the big boss from Barcelona, and Phil Cornford and his team who lead the prostate cancer guideline. But the three things I put out a tweet about, see if you agree with me, Yao and Junlong, were, first of all, they did strengthen the recommendation for transperineal biopsy. They had already introduced it as a recommendation about 2 years ago that we should do transperineal instead of transrectal because of the lower infectious complications. And this is before some of the randomized trials came out in the last year. And then this year, they further strengthened it to say because of antibiotic responsibilities or stewardship. So it was further strengthening us to think, look, it's not just maybe lower infections, although the infections aren't that lower really in the randomized trials, but also we have a responsibility to try and not waste antibiotics if so. So that was one comment, I think, and we'll come back in a moment and talk more about that when we talk about the Translate trial. The second thing I commented was last year the EAU changed, you remember, to really downplay pelvic lymph node dissection. They really did. It was a big headline from the meeting last year was they dropped the recommendation for pelvic lymph node in intermediate risk cancer, no mention of nomograms. And even in high-risk cancer, it was kind of made
the wording
optional.
really changed, didn't it?
Really emphasis changed, which I think is still a bit contentious. So, and this year, basically, they made no change to that, despite the fact that there is a randomized trial, which we talk about in this podcast, the Memorial Sloan Kettering trial, which still puts some question marks, I suppose. But the EU guidelines were not impressed. They didn't change. They said, no, And then thirdly, I suppose maybe a strengthening again of the role of MRI in early detection for prostate cancer. really emphasizing targeted biopsies, but also still systematic biopsies should be considered for most patients. And I know from our previous China themed podcast that in actually the one we shot from Shanghai in December, EAU, I was very impressed to hear the number of centers that have access to good quality MRI in China. I know it's variable, but still very impressive. MRI is being used quite a lot. And finally, and I'll hand over to you for comment then, Yao, the ARANOTE trial, of course, read out at ESMO a few months ago, this time giving us the evidence we need for darolutamide as a doublet in metastatic hormone-sensitive prostate cancer. So now we see that that's clearly got its role in the guidelines as well, unsurprisingly, but previously it was sort of limited to triplet with chemotherapy. Here in Australia, we've been using darolutamide as a doublet kind of off-label with funding for a long time. But now that the ARANOTE trial has been published for RPFS, the primary endpoint, we're bound to see it emerging in guidelines like this and also hopefully getting reimbursed. So have you any other comments on the guidelines before we go to
I think
Yao?
that was a pretty comprehensive overview, Declan. I'm interested to see how it's been received over there, Yao Zhu and Junlong. What are your thoughts?
Yeah, I think Declan make a very comprehensive overview of the guideline changes, and each year EAU guidelines they make step progress to high value the highest evidence in each aspect. So this is why EAU guidelines they are so popular across the world. And this year we see a randomized surgical trial in EAU meeting. I think it's a huge breakthrough in this area. We know we are urologists, and we both know how it is difficult to confirm the surgical trial, especially so many centers, and you have to standardize the procedure for each surgeon participating in this kind of trial. And we are wonderful to see the Translate trial and the NeuroSafe trial. Although we do not have formally performed the NeuroSafe in our center, we do have some experience to test the surgical margins in some patients with high suspicions of tumor in the NVB site. And I think this trial showing the improved erectile function after such kind of the limited but precise surgical excision of the tumor without compromise the neural function. And for the Translate trial, I think it's really practice changing and confirm that transperitoneal biopsy is the standard of care. But a point I want to mention is that in this trial, the trial excludes like 10% of patients which may be immune compromised or some kind of reason comorbidity need antibiotics enhancement. So I think there is still a small group of patients may need some kind of antibiotics to guarantee the safety in the transperitoneal biopsy. So I think this trial are really informative in each aspect, and I'm really glad to see our urologists can perform same qualitative trial compared to other oncologists in this space.
Yeah, it's a good point. It's good to see these surgical randomized controlled trials kind of taking center stage, isn't it? They're not easy to do.
And during COVID as well, actually,
absolutely.
these trials, yeah.
And two that came out of the UK, it's very impressive. And just in keeping with the guidelines that strengthen the recommendation to do MRI in detection, I think that's one of the strengths of the Translate trial, that all these men had an MRI.
Yeah.
So it really kind of catapults this trial into the current now, doesn't it? And very relevant to our pool of patients.
And the thing is, Renu, and I'll ask Junlong for his thoughts on this, the primary endpoint of the Translate trial was not about infections. It was about cancer detection, wasn't it?
What was that famous saying, Declan?
Yeah, Richard Bryant, the co-lead who read out the trial, said, "A man does not undergo a prostate biopsy to avoid an infection. he undergoes a biopsy to find out, does he have cancer or not? Because in recent years, we've got all very distracted about the infection side of things. And actually, the 4 randomized trials have shown that trust biopsy, now you do need lots of antibiotics, is not as bad as maybe, we thought it was.
Yeah.
But you do need antibiotics. But more importantly, in this trial, Junlong, Translate trial, 1,100 patients, they all had an MRI scan, randomized for trust biopsy with targeting or transperineal under local. And they showed that the detection rate of significant cancer was significantly higher in the transperineal group. So it met the primary endpoint. And that's the most important reason why a man has a biopsy. So what do you think? What is your interpretation of the Translate trial? Specifically about this issue with the cancer detection rate being better?
Be frank, when I see the data from the Translate trial, I'm confused because because I believe maybe the transperineal way will be lower, maybe lower infection than the transrectal ways, but it's not. But there's no difference, and but the significant prostate cancer detection they have the difference. But I'm very confused because all of other maybe of other clinical trials that two ways there's no difference about the prostate cancer detection rate, only about the target maybe target biopsy plus maybe target biopsy will increase the PSA detection. And that had been proven by many clinical trials. So I don't know why transperineal ways will detect more prostate cancer. Maybe Declan, do you give me some reasons about this?
Yeah, look, I agree with you. It's so nice to hear. I'm confused because we all get confused, don't we? But look, I suppose some people will speculate that maybe the anterior tumors, maybe in the bigger prostates, might be more difficult to access transrectal. But on the other hand, I only do transperineal biopsies for 15 years now. And sometimes anteriorly, it can be difficult to access under the pubic bone in some patients if you've got a big prostate or the pubic bone is quite low, But in those patients, we have tricks of how to get there. We flex the hips back way more. We can freehand guide the needle in there. But I'm guessing it must be reasons like that the targeting is better with transperineal. And whether we're still confused or have an explanation or not, this trial is powered to detect that difference, 1,100 patients. And so we must accept it as the best possible evidence. And also, importantly, the authors, Richard Bryant and Alistair Lamb, who joined us on the podcast, they went to great lengths to say that the number of cores that were taken in the transrectal and the transperineal were the same, didn't they? Sometimes we take more cores transperineal, so it might be a sampling issue, but they were really pointing out that the number of cores was the same. So that's not the reason either.
I mean, I think for many years we've inherently thought that transperineal was better because you do get better access to that anterior aspect of the prostate. Yep. But I mean, this is the first trial to have shown it. And I think also the fact that all the patients in the trial had an MRI as well also makes this a particularly strong finding. So it seems hard to ignore, doesn't it?
I think experienced maybe doctors will not lose the arterial zones in the prostate, and every patient in our center we will perform the MRI 3.0 Tesla MRI, and the experienced doctors will not lost the lesion and on the arterial zones on the prostate. So maybe the Translate trials, I believe, maybe performed in Chinese, but maybe the results were different.
Good point.
Yeah, you do always wonder that every time there's a trial, you have to say, well, that's in that country or that setting, and you try and interpret what it means for us. But yeah, what about the question of antibiotics? Do you have pressure in China? Like, for example, I was in the discussion at the EAU for this. I was leading the discussion, and I pointed out that we have these constant messages from the World Health Organization and others to say, we need to be careful with antibiotics. The super bugs are coming, and if you can do a procedure without antibiotics, like prostate biopsy, with a better cancer detection rate, you should do the procedure that doesn't require antibiotics rather than the procedure, trust biopsy, where you must use antibiotics. So what do you think? What will authorities in China say about antibiotics in future years?
Yeah, I think the regulation of antibiotics in China is strength now, and we have strict guidelines to use antibiotics, especially for pre-biopsy or post-biopsy setting. So we really value the data from the Translate trial, which I see the infection rate by the transperitoneal approach is less than 1% after the 4 months. So it's quite a low rate. And during my resident training phase, I see patients from the transrectal biopsy get species and have to transfer to the ICU for antibiotics infection to control the infection. So it's really a disaster for not only the patients, but also for the doctors to control a very difficult situation after a biopsy to confirm a country which may not be very lethal to some extent. So for me, I think the interesting part is that we see from the Translate trial, nearly half of the patients get diagnosed of aggressive prostate cancer after transperitoneal or transrectal approach. So this thing were not similar in China because the overall prevalence of the prostate cancer is lower from when we compare the Chinese to the Western counterparts. So especially given such a low cancer detection rate in Chinese patients, we should value the benefit of transperitoneal approach to prevent infection. And I think the benefit and the risk ratio in Chinese patients is much higher compared to the Western counterparts, especially given the low cancer rates compared to the UK patients.
That's why we love doing this podcast, where we're going to focus specifically on how you interpret this in a huge country like China. I get it.
Very interesting views, definitely.
And before we move on to the NeuroSafe trial, Junlong, can I ask you, what proportion of prostate biopsies in your center or in your region are done transperineal? Is it still mostly transrectal, or how many patients get the transperineal biopsies these days?
I remember about 6 to 7 years ago, we start to the transperineal prostate biopsy under local anesthetic, and then after that we do even we don't do even one case using the transrectal ways. So all patients do the transperineal biopsy. And our defection, our infection rate is less than maybe 0.1 percentage.
With no antibiotics.
It's very, very low. It's very low.
That's just amazing.
Because as said by Dr. Zhu, we get some transrectal prostate biopsy, and some patients got the grade 5 adverse events. Grade 5. So it's we can't accept that. So after that we all change the biopsy ways to the transperineal.
Wow. I'm sure it varies around the country, but that's really interesting to hear. And I'm still convinced, Yao Zhu, that in future years we may be told by authorities that you are not allowed to use antibiotics for a procedure that can be done without antibiotics.
Yeah.
It may be a serious thing that these are restricted access to quinolone antibiotics. We may be told, no, you can't do that. Large trials showed that you can do this without antibiotics and you have a better cancer detection rate. So look, I concluded in the discussion that, both approaches still have merit, but I think the direction of travel is to move away from transrectal. And that's my thought on it. Now, the NeuroSafe. We want to talk about NeuroSafe because this is very, very interesting. And I'm really interested to hear, is everybody in China now doing frozen section? But just in brief, if you didn't read about the NeuroSafe proof
or watch our podcast.
Or watch the podcast, because we did do a really detailed podcast with the authors. So this was another one of the very big headlines for the EAU this year. The NeuroSafe randomized trial read out. And so this is a randomized control trial in the UK led by Greg Shaw and Owen Deneen and Almeida Magdana from UCL. And so they took men who were sexually active and scheduled to undergo radical prostatectomy. And they were randomized to just get nerve sparing as planned by the usual means, MRI scan or biopsy results, or to have nerve sparing using the NeuroSafe technique, which means that in surgery, at the time of surgery, the prostate would be removed, and then a pathologist would perform a frozen section on the margins of the prostate to see was there any cancer present. And then if there was cancer present, the surgeons were still in there and they could remove some more tissue. The idea being, if you have the frozen section available, you can probably do more nerve sparing. You can increase the proportion of patients that you can do nerve sparing on. So what did they show, Renew? Yeah, that's what they showed. They showed that in the control arm, about 50% of patients had bilateral nerve sparing, whereas in the NeuroSafe arm, it was like 85% or 83%. So NeuroSafe gave you the ability to be more confident about getting a clear margin. And did that lead to better sexual function at 1 year?
Yes, it did.
Yes, it did. The shim scores were up and it was clinically meaningful. So this is big news for patients and surgeons to say, if you have NeuroSafe or frozen section assessment of the margins in surgery, you can increase the proportion of nerve sparing and that will be of value to the patients.
And particularly important in those patients that you really want to do a nerve spare on, but for certain MRI features, you would be a little bit more cautious. And in these patients, you still can do a maximal nerve spare and go back and take the nerve bundles if there turns out to be a positive margin. So really useful in these patients, isn't it?
And long before we got back to Melbourne, the office is ringing us to say the patients are all asking, can they have NeuroSafe, because it was in the newspaper as well. But we've tried this before. I mean, NeuroSafe's been around for years from the Martini Clinic. We brought the surgeons down here. We took the pathologists out for dinner. They said, no, it's impossible. We can't do it. We can't come into the operating room for every prostatectomy. We have hospitals all over the city. It's impossible. So,
and the interesting thing is, after EAU, we were in London and we were at London Bridge Hospital, and we saw this in action where the surgeon would remove the prostate, take it just next door, one door away, where the pathologist was just waiting to receive this. And within 15, 20 minutes, before you could finish an anastomosis, you would have the result. And we realized that that's what it takes to make something like this time efficient and work. And unfortunately, not every center in the world can do that.
Yeah, very few. Well, let's ask our friends whether they can do frozen section on all their radical prostatectomies in China. So, Yao Zhu, first of all, what did you think about the NeuroSafe trial? And then, second, please tell us what happens in China or what will happen.
Yeah, so really nice surgical trial, and I have previously watched the procedure on NeuroSafe, and I think even in very experienced center, it usually take an hour to finish all these procedures. And if there is a positive tumor in the frozen section, the surgeon have to wide resection of the NVB bundles. And from the paper published, I see really improved erectile function after the NeuroSafe. But my point is that although nearly 80% of patients in the NeuroSafe arm underwent the bilateral nerve sparing, only 40% of the patients get only mild or no erectile dysfunction, which means half of the patients get the bilateral neural safe and nerve sparing approach. Only half of these patients get a nice erectile function after this surgical approach. So my advice to the patients who are enthusiastic about this approach is that we can do in some limited case with intense work of our pathologist to work similar to the neurosafe. However, the successful rate, which means only mild or no erectile dysfunction, is only about half of the results outcome after the bilateral nerve sparing. And in our center, we do some section for patients with suspicious of tumor in the apex region, or some, the yellow surface of the prostate very nearby the NVB bundles. We do not routinely perform neurosafe, and we do not routinely send a large frozen section to our pathologist. We only like some small specimen with suspicious of positive surgical margin in our patients.
Very good.
Yeah, good interpretation. It's a reminder of the impact of treatment of prostate cancer on sexual function. Regardless of this improvement, it's still, an area for more improvement.
Yeah.
But Junlong, so what do you think in your center? Would you find it easy to do a frozen section on your prostatectomies if you asked for this?
First of all, and the neurosafe, I think it's a better technique and can provide real-time pathological consult to doctors and promote the optimal. Maybe we can preserving more new neurovesicular bundles, and also avoiding positive surgical margins. It's a very nice technique, and we want to, and we ask the radiologist to give us to this technique. But for now, we don't have that. It's very complicated questions about the hospital, about the pathologist, and other questions we need to overcome. And in my opinion, more patients in our country, in our center, they concern more about the functions, especially about the continuous functions and the sexual functions more than the margins, maybe more than the margins. And they believe if they had the positive surgical margin, they also can receive the radiotherapy, ADT. But if they lost their function, they never come back. They will lose them forever. So more patients in our center, maybe in our country, they have more needs about the sexual function. So maybe the technique will be more popular in our country.
Oh, that's very interesting to see how things have evolved over time with what patients are wanting.
Yeah. And, the point is, it's not a bad thing sometimes to say, look, I really want to preserve my sexual function and I don't care so much about the positive margins. If a patient says to us, I understand positive margin, it might be important, but sometimes it's not important. Maybe they will accept the possibility of the positive margin. But I suppose the point of the trial is it gives us an opportunity to try and improve our technique to do more nerve sparing without sacrificing the margins. Although the margin rate was a little bit higher in the NeuroSafe trial, so it will need further follow-up.
But I think the important takeaway from this trial is that intraoperative margin assessment is important. Now, how we do that might be different. It might not be pathologist dependent. For instance, there are various technologies out there now that can speed up this process and not rely on the human touch at the time of surgery. So I think these things are going to become more interesting as they evolve into the future.
Well, you're so right. And let's hear, is there any development of this in China? But the whole area of, as you said, intraoperative margin assessment is now very hot topic because of NeuroSafe, but everyone has the same issue with the logistics of the frozen section. But other technologies, as you say, so we spoke a bit on the podcast about them, the confocal microscopy using histolog and vivoscope. There's an intraoperative PET thing, the PSMA PET.
Yeah,
we saw the machine last year in Europe. And
various AI technologies.
Yeah, Raman spectroscopy with AI.
Yeah.
So these are all ways that the intraoperative margins might be assessed using devices we can have in the operating room that might be a lot faster. And this is interesting, isn't it?
Yeah, I mean, I think it's going to be a very exciting field. And I think for me, that's the biggest takeaway from this trial, that intraoperative margin assessment is important.
And we're about to start an experience with the histolog machine, a confocal microscopy. But I suppose that's the final thing we want to ask you about, Yao and Junlong, is do you have any knowledge of these other technologies that can be used for intraoperative margin assessment, such as the histolog machine or so on? And let us know what your thoughts are.
Yeah, I totally agree with Renew and Declan's point. And I think we have some nice experience with the blood cancer and with different confocal and different tracers, we can detect the residual tumor after the conventional resection. So if we can improve the time and the precise, we can detect the tumor near the NVB. Maybe we can improve the NeuroSafe to a next step, because it's still time consuming and resource consuming. And in our center, we do not have specific development in this area, but we see some attempts in collaboration with the university, trying to use different kind of tracers, something like the PSMA or some, the AI exploration of the imaging during the surgical field, which take a small time to see the reflection of the conventional or specific light to the tissue, and we get the reflection of the light and interpret this of the information to confirm whether we can spare some of the NVB or we should resect all these tumors. So it's an interesting space to explore, and I think the space for improvement is so large, and every attempt to improve in this space is encouraged, and we are very glad to work with the scientists in this space.
Very good. Totally agree.
Junlong, anything else you want to add on this intraoperative margin assessment?
Yeah, I totally agree with Dr. Zhu, and all our attempt, all our try is to try to preserving more tissues, more MVBs, and to prevent the patient's functions, maybe urinary functions at the first, and but now we just using the processing imagings like MRI, like the plasma PET CT, and to guide us to do the processing surgery. We hope and maybe the NeuroSafe is just the first. Maybe there will be second, maybe third technique where to help us to make the make the operation more precise.
Very good.
And I think that's what the next few years we'll see, more and more of these clever devices, coupled with AI technologies. What we'll need to do is large randomized trials like NeuroSafe to prove them. But it's exciting times, Renew. I feel optimistic.
And remember, we saw that intraoperative PSMA PET scanner at ERAS last year, and it's so compact. It will just fit in the corner of the operating room very nicely.
Yeah, you take out the prostate,
Yeah,
pop it in this.
pop it in there and you get this-
It goes down in the lift and comes back up. And so I think the technology will,
It's incredible.
and it'll probably come out of China, of course. They're very good
That's
at
right.
very good at
We'll
all
look
this.
to you guys for sure.
Yeah, so look, well, that was really
Yeah, it was
enjoyable. Well, thank you so much for joining us and for bringing Junlong along. Have you any finishing comments for us before we sign off today?
Yeah, so it's really wonderful discussing, and I'm really honored to be invited in this discussing with Decline and Renew and with my dear colleagues in China. And I think every time I finish the talk, I have a lot of sparkles in my brain, and I trying to not only to get the new information to my clinical practice, but also a lot of thoughtful ideas. Maybe we could collaborate to develop in the near future. So really thanks for the opportunity, and really glad to join the GUcast again.
We always enjoy having you.
Yeah,
Shu.
and likewise, Junlong, thank you for joining us. And I suppose this is the first one we've done from the studio for China, because we did 3 from Shanghai up
That's
in
right,
December, which was
yes.
very, very enjoyable to be up there with you and see you all. And we look forward. We're going to do the same again, I think, later this year. We're going to go up to Shanghai, and the Bayer team will build us that lovely studio again.
Amazing.
We'll make some great podcasts up there.
We
again.
feel at home.
Yes. So great. Look, Junlong, thank you so much for joining us as well. And Dr. Gu didn't make it today, but perhaps we can extend the invitation for the next podcast for him to come and join us. Renew, that's all we have time for today. Just to thank our friends at Bayer in China for, again, supporting us as gold partners and allowing us to put on these theme podcasts. They also support our conference highlights, which are very, very popular. And we've already posted both of our EAU podcast highlights episodes by the time this one goes out. So thanks very much to Bayer China for all of that. That's all we have time for on this episode of GUcast. We wish you all the best, and we'll talk to you again soon.
See you next time.